Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas from Tehran, and once again, I'm so honored and grateful to be with you all from this educational platform. And I have to say again, I'm super excited because I have a dear friend and I have a special guest, Joseph Kahn from United States here with us. And I'm pretty sure all of you as a dentist, as a periodontist, as an implantologist, as a prosthodontist, know this gentleman because all his all his researches and all he did for our profession as a leader, as a true educator, and I just have to say I'm so thankful for that, and I'm pretty sure in the next hour and a half or next hour you will all enjoy his tips that he will provide for all of you, and it will be beneficial for all of us. So with that said, I welcome you, Joseph, to Hot Seat, and thanks again for accepting my invitation.
So, Omid, thank you for so much for inviting me and to be part of this amazing seminar you have.
Thank you so much. So happy to have you. And for all the audience, Joseph, if you let me, I wanted to just make an announcement. Hopefully it happens because of the situation that now we are facing all over the world. But hopefully Professor Joseph Kahn will be our keynote speaker at the 5th International Symposium of Complications in Implant Dentistry next year in Tehran, if the situation will be under control. So just wanted to let you all know about that great happening. So Joseph, before we start, as a tradition, I would like to have your CV for all of our participants because I know they all know you, but it's just a tradition. I just wanted to have your CV for all the participants. Dr. Joseph Kahn completed his specialty training in prosthodontics as well as the master's degree from the implant surgery from Loma Linda University School of Dentistry in 1997. He is currently a professor in the Department of Restorative Dentistry and the research coordinator for the implant dentistry program in Loma Linda University School of Dentistry. He also maintains a private practice limited to prosthodontics and implant dentistry. In 1997, Dr. Kahn was the recipient of the Best Research Award in the 12th annual meeting of the Academy of Osseointegration. He also received the Hudson Hinsky Scientific Award from the Journal of Prosthetic Dentistry in 2003 and the Robert James Achievement Award in 2005. Dr. Kahn is on the Periodontology Implantology Editorial Board of the Practical Periodontics and Aesthetic Dentistry. He is a member of the American Dental Association, Academy of Osseointegration, American College of Prosthodontics, American Academy of Fixed Prosthodontics, and associate member of the Pacific Coast Society of Prosthodontics. He is one of the few clinicians worldwide that have been trained in both surgical and restorative discipline of implant dentistry, besides lecturing both nationally and internationally. He has published so many articles in the field of perio and implant and prosto in reference journals and chapters. So yeah, so with that said, again, I'm so happy to have you. And today's session gonna be more like a question and answer and talking on different aspects in implant dentistry, mostly focused on aesthetic, hopefully. And I think it will be full of educational tips for all of us. So Joseph, let's start with the concepts in implant placement, as you are one of the pioneers, or actually, as I remember, you reported immediate implant placement in 2003. I think you were the first one to brought that concept for the dentists and implant surgeons. So first of all, I want to know your opinion on that and your thoughts that now in 2020, after seeing all these after having all these experiences and seeing the follow-ups of the patients, in what scenarios do you recommend immediate implant placement? And in what situations you prefer to do like early approaches?
Okay, so first of all, um, I am really not the first person who talk about or publish about immediate implant placement. I did publish a few articles on that. So if you look at immediate versus early implant placement, um, traditionally, what is indicated for immediate is in the most ideal situation. What that means is the bone and the soft tissue need to be pretty much within normal limits. That means no significant bone loss, no significant recession. And but nowadays we had evolved somewhat to the point that we realize that even now in a extraction socket, despite the fact that the buccal plate is somewhat compromised, as long as the defect doesn't encompasses the bone of the adjacent teeth, we found nowadays we can still do immediate implant placement and then graft and get very good results. So in general, the guideline for immediate should be very rigid. Now, of course, as a clinician, you can do whatever you want. You will once in a while hear clinicians show you that a case has absolutely no bone. There's nothing there. And they put an implant in there and somehow they show you the case looks beautiful. But please remember, what I'm trying to share with you is the mainstream trend. That means you as a clinician, an average clinician can achieve that success. So if you're an average clinician and I consider myself not superior, I'm in the middle somewhere, my comfort zone is as long as the bone socket need to be intact, the ginger need to be within normal limits, I can get very good success on immediate implant placement. Now, when do I do early implant placement? I do my share of early implant placement, but again, from my standpoint, if I have a situation is ideal, I will definitely go with immediate first. Now, early implant placement is when the defect is compromised. I mean, we're talking about there's no bone for implant stabilization. There's like massive infection. That's when you want to remove the etiology of the problem, such as the failing tooth, let the body heal before you re-enter the site and put the implant in. However, based on my experience, this is what I've learned. If we have a situation, a case that is not indicated for immediate implant placement. Why? For example, there's no apical bone for stabilization of the implant. Or maybe the root is way too long, so again, there's not enough bone for stabilization. Or maybe because the socket is so compromised, the bone is just simply not there. Under such circumstances, we know, I've already told you, I will not do immediate. If I decide to take that case to do early implant placement, my experience tells me more than 60% of those cases, when I reopen the surgical site, the flap, 8 to 10 weeks later to do early implant placement, I found out that those cases, I actually still cannot do early implant placement. Why? Because if the bone is not there, or 8 to 10 weeks later, without putting any biomaterials inside the socket, what do you expect to see when you open the flap? Do you see like the ridge like with perfect bone? No. As we say, a lot of times, actually 8 to 10 weeks later, Omid, you're experienced enough, you go back in, you see granulation tissue, you clean up the granulation tissue, you still see that defect in there. And you still cannot really put that implant in there. In fact, you need to do GBR first before you can put the implant in. So that's my experience on when to do immediate, when to do early. And the best type of early placements are the cases that, that is ideal for immediate. If the case is ideal for immediate, for sure early will work perfectly.
Yeah, yeah. And speaking of that, speaking of extraction sockets, so as you said, immediate placement needs a rigid protocol. So for example, we can say that type 1 sockets works best for immediate implant placement. And if the tissue is thick and we have thick biotype, it's even better. So now let's compare it to type 1 sockets that we have thin periodontium and thin biotype. Now, in such cases, now we don't talk about type 2 now, but only in type 1. In type 1 sockets with thin biotype, do you prefer to do soft tissue graft simultaneous with immediate implant placement in all the cases? If not, what will be your criterion decision making?
Well, thin gingival type is always a tricky issue. Why? Because people think you increase the risk of recession, you will increase the risk of discoloration of the gingiva. All right. So that's always something that is challenging for clinicians. What I do in situation in lieu of a failing front tooth with thin gingival biotype, and the way I analyze thin gingival biotype is I use a periodontal probe on me, as you know. I probe the sulcus to see whether I can see the outline of the probe. If I can see that, it'll be on the thinner side. Then what I do, if the patient needs an implant, is I will look at two things. Number one is I would definitely consider doing soft tissue grafting. And either the way I manage it is either I raise the flap or I use a tunneling technique. All right. And other method is if thin gingival type, if the tooth is maintainable, but the coronal part of it is gone, I would definitely look into like a socket shield type of scenario. So that's how I manage it. Either I do a grafting, or if I can do socket shield, I will consider doing a socket shield situation.
Okay, perfect. And because I will go to the socket shield, and I really wanted to know your thought on CTG and connective tissue grafts, so you confirmed it. And now if we move to type 2 sockets, and if we have it, soft tissue is there, but we have a dehiscence or in different shapes. Now, you have a great article on different morphology of dehiscence defects, whether it's a V shape or U shape or W shape. So because we see many articles coming out and showing different protocols, some people place the implants and put a membrane, make a tunnel, pack the bone. Some people, do at the same time reflect the flap, do the GBR and place their implants. Some people don't do anything, and as you recommend in your articles, they wait, especially in U-type and W-type shape defect. So I want to know your recommendations on that generally, on type 2 sockets.
Okay, so type 2 sockets, as I say, nowadays we realize as long as the buccal bone defect doesn't encompass adjacent teeth, like in a Y-U-shaped defect that you're talking about, immediate implant placement, and if you put a provisional in there with some sort of GBR and soft tissue graft, you can actually get very minimal to no recession. So we know now it works. The question is how we manage it. You mentioned it. Some people do flapless, some people raise a flap, some people, like whether you put a membrane or whatever. So there are many ways to do it. In my hands, over the years, I had achieved good success, either flapless or flap. However, I must warn the audience that raising a flap is always easier for you to visualize the defect, easier for you to clean the infection away, and even grafting, as you know, Omid, when we do bone grafting, if you use membrane, you can really control the site really nicely. Now, on the other hand, when we do tunneling, the drawback is this, is a little bit more technique sensitive, and you're trying to tunnel membrane or tunnel things in there. A lot of times, and I have many cases that I intentionally do a flapless surgery, do bone graft, tunnel membranes, do all kinds of things. And then I intentionally just raise the flap and take a look. To be honest, the membrane is all bunched up like this. You know what I mean? It's never like a nice membrane, really clean, something like that. When you raise the flap, you can just do control things. A lot of times when you do tunnel, things are all bunched up, but we don't know. We thought everything's good, right? We raise the flap, it looks like this. It just looks like this, right? So that's my main point. So now, does that mean I never do flapless? I do a lot of flapless cases. So when I do it, for example, patient really thin gingiva, highly aesthetic scenario, and high smile line, and patients demanding, I tend to go a little bit more towards flapless. Okay, and what I do is this. It's not 100% flapless. A lot of times what I do flapless is at the gingival architecture, I don't raise the flap around the sulcus. But I will do almost like what people like, if you listen to like some people, those tunneling technique like pinhole or vista, I will do another incision in the vascular area and just tunnel it so that I can get better access to clean things up. All right, so the goal is not to get things fancy because like you want to make sure that the site lasts a long time too. So that's why I stand. So again, to put it in summary, If patient don't mind, if I can raise the flap, I'll raise the flap. I'll clean everything up and do the grafting. I'll do bone graft, membrane, soft tissue graft, and suture. And then, but however, if the patient is aesthetically demanding, I will try my best not to reflect the gingiva if I can. Some cases I cannot. I still need to raise it, but I will augment with maybe some sort of like vestibular incision or tunneling incision, so I can also tackle it from the vestibular area to ensure I can get good control of the grafting.
Yeah, you're right. And now when we are talking about the aesthetic zone with the approach that you mentioned, for instance, that we reflect the flap, do the contour augmentation in the case of dehiscences, and then we close the flap. If the patient's aesthetic is demanding, and if we want to just put a provisional there, do you prefer to go with the fix, or is it possible to go with the removables? And if in cases that we have crowns in the adjacent area, for example, if it's not possible to go with the fixed retainer or resin bonded bridge, then what will be your recommendation on provisionals for the patient?
Well, the thing is, not every situation you can do immediate provisionalization. Some clinicians, maybe the implant stability may not be enough, right? And what I mean by is, in my opinion, if your insertion top of the implant is less than 20, 25, I probably will be a little bit hesitant to put a provisional in there. And or maybe what happens if a patient is severe bruxer, all right, have very bad functional habits. Then again, putting a provisional in there will probably increase the risk of failures. So in those kind of situations, how I manage is this. It depends. Every situation is different. If I can, but what I do is this. I will use some sort of either provisional situation like a flipper, or maybe I'll go in there. Let's say if adjacent teams are very prepped, I will just do a provisional bridge, all right? Or maybe even like an Esthetics retainer. However, the key is not to let the gingival architecture collapse in. So in those sort of situations, such as if I'm going to do a resin bonded bridge, flipper, Esthetics retainer, a provisional bridge, the way we, as you well aware, the way we can maintain the gingival architecture is after the implant place, we put some sort of temporary cylinders in there, and then use either composite to develop the gingival profile, right? Reshape it so that it's just like a provisional without the coronal part of the crown, just to maintain the gingival architecture. Then on top of it, I can throw in any type of removable Esthetics or like a fixed provisional in there. That's how we manage it. And I'm sure that's what you do too.
Yeah, like a customized healing abutment, as you said.
That's right.
Just to save the subgingival contour of the gingiva and
that's right.
Not to do anything with the coronal part. So in cases that we are doing type 1 sockets, whether it's thick biotype or thin biotype, about the gap management, different concepts available. Some people recommend to pack the bone graft materials to the implant level and then do the provisional. Some people recommend to graft up to the gingival margin and then put the provisional, and they are saying that the particle grafts maintain the area between the soft tissue and the provisional and make sure there is no way for collapse in the tissue. And some people going with the soft tissue grafting for saving the contour in the top 3 millimeters or coronal 3 millimeters of the socket. So what's your thought on that?
Okay, so basically I've tried all three methods that you described. And all three methods, I have success. Once in a while, I also have cases that doesn't turn so nice. All right, so let me make sure you understand what I mean. Like what you described is either when you manage the gap is graft to the implant, graft above the implant into a gingiva. We, like dentists now call it the dual zone technique, right? Dual zone grafting, or maybe you graft and then put the tissue graft. For me, first of all, what I prefer is I always put bone graft above the implant platform. All right, I always do that. I seldom just put it right onto the implant platform, because no matter how careful we are, there's always some graft sitting above it. All right, so no matter what, there's always gonna be like that. Nobody is so careful that you just put it right at the platform and that's the end of the story. So when I graft, I always graft above the platform. So you can almost call it a dual zone if you believe in that. And do I do tissue graft? Yes, I do. But I will tell you, I have done cases that I did immediate implant placement graft about the platform, do a tissue graft, and then after the healing is not so nice. I mean, it's still acceptable, but the gingiva you can see, I mean, if I were to use, let's put it this way, I will not use that case to lecture on a big podium to show how good I am. That for sure, no way. All right, it will not be that perfect that every people say, "Wow, it's an amazing case." And I had that happen to me, when I do dual zone, and that happened to me if I just pack it in my platform. So all the techniques has. I can show you cases that work. I can also show you cases that doesn't work. However, majority of the time, it works decent.
Mm-hmm. So it just the surgeon's preference, as I get it, right?
It's a surgeon preference, but for me, I will always prefer to do a tissue graft.
To a tissue graft.
I will always prefer to do a tissue graft on top of that.
No, even if it's thick biotype or on thin biotypes.
Great question. For me, because it's so hard to differentiate between thick and thin biotype.
Yeah, you're right.
My workflow is this. Every situation, in practice, the way to make money is you keep repeating the same thing. You don't just try to, okay, this one we'll try a different graft, try a different thing. If every case like that, it's really complicated. So for me, I treat every case if it's a thin gingival biotype, all right? And I always use autologous soft tissue graft because there's no overhead. It just costs me the blade, that's it, and suture. So it doesn't cost me any money. And for me, you're a periodontist, when we harvest a soft tissue graft, how long it takes? Less than a few minutes.
Yeah.
We're done. So it is something that every case I routinely just keep repeating the same thing over and over again. So every case, yes, thick gingival biotype, I would still consider it as a thin, thin gingival biotype because it's so difficult to quantify what is thick and thin.
Yeah, exactly. You're right. And speaking of connective tissue, again, we have great sources like tuberosity, like diepithelial free gingival graft, or connective tissue from the palate. And we have different reports regarding the different reactions of the soft tissue graft. So in the cases of aesthetic zone, in the cases of we want to thicken the biotype and increasing the contour, which source do you prefer to use?
Okay, so, the other day I had a good discussion with my dear friend Sukeli, Giovanni.
Yeah.
And I tell you, I have my experience, I'll share with you. In general, people always feel that if you take a soft tissue graft in a subepithelial connective tissue graft way, in the lateral palate, a lot of times you have fatty tissues, you have all this granulation tissues that you need to really clean it up. If you don't clean it up, the result may be compromised.
Yeah.
Trust me, I have a lot of cases that I have, and sometimes when we harvest subepithelial connective tissue graft, they are seldom like a really clean piece of white meat. You know what I mean? A lot of times it's like red, a lot of yellow tissue. And if you trim everything away, you have nothing left.
Yeah.
So what do we do? I'm sure, Omid, you have grafted, you use that as a graft too. And the results, are they bad? No. I have a lot of cases, even the tissue is really like fatty like that, and the results are beautiful, okay? So, scientifically, do we really know? Is there enough research on it? I don't think so. I doubt it. If you read the literature, there's no clear guideline that, okay, if you use tissue that's really fibrotic, for sure, you can be much better success than if you have a piece of tissue with some fat and those kind of things in there. However, okay, I must say that if you want tissue that's really firm, then you got to go to the tuberosity or maybe the molar area. For me, what is so unique about getting tissue from the tuberosity or towards the molar area, doing what like Sukeli advocated, the epithelialized FGG, is that I noticed, I'm doing a study right now, I noticed that tissue from those areas have a higher propensity of what you call proliferation. I recently read an article by the group from South Africa, my dear friend, Howard,
Yeah.
Glaitman, and then they describe, some cases they see proliferation, as some other articles that see. I noticed, at least from under my hands, I find out that when I harvest tissue from the tuberosity or the epithelialized FGG towards the molar area versus the lateral palate, those areas in the posterior region, more fibrotic, the proliferation rate is very close to 30% of those cases. That means 30% of my cases, I sometimes see a little bit of, gaining rather than shrinking down. Yeah. So if there's any benefit, that's where I see on that. I'm sure you sometimes observe the same phenomenon.
So is it considered as an advantage or disadvantage in aesthetic cases?
Okay. Sometimes it's a disadvantage, but let me tell you, for me, when I do contour grafting, all right, I actually prefer to have a little bit more tissue. Mm-hmm. I actually prefer that because when we do contour grafting, the decision always for me is either do bone grafting, such as using xenograft, like a biomaterials, and in fact, like people like Dan Rebuser, that's what they suggest. But I noticed that when I just use like a tissue graft, the unique thing is, biomaterials, when you try to put a contour, they will only shrink. Mm-hmm. The chance of it staying 100% is rare. Even if you use xenograft that's very slow resolving, they will usually shrink. However, with soft tissue graft, the unique thing is 30% of them, they expand. Yeah. And honestly, I rather have a little expansion than shrinking for me, because if it expanded, I can always take a burr and just kind of like shave it down, right? But if it shrink, what you're gonna do? You're gonna do a second surgery, right? That's where I stand on that. Yeah. So that's why I feel as a surgeon, on contour grafting, the benefit of doing that tissue graft very important, because tissue graft 30% chance it will expand.
Yeah, you're right. That's actually a great point, because for extra tissue we are okay, but when we face the lack of tissue, then talking to the patient and make him or her satisfied to do it again, sometimes it will be an aesthetic problem for us. So exactly, I'm totally agree with you. And now let's go to like more new approaches. Like actually now we see that we have reports like 5 years, 10 years data on the socket shield and partial extraction therapy. And the way that it's presented and the way that we see the predictability in the treatment and in follow-up of the patient regarding the volume and contour stability, well, the results are very promising. And different groups like Marcus Herzeler, yourself, Howie, Maurice, and all these people demonstrated very beautifully. Now I want to know this, because socket shield is kind of technique sensitive and we have protocols for that. So first, my question is, I just want to know your thoughts on that comparing to other techniques. And for example, if you are seeing a case, it's high smile line, thin biotype, all the risk factors and predisposing factors, as you mentioned, are there. So you want to decide, do you prefer to go with the socket shield comparing to other techniques, yes or no? And the second part, I want to know your thought on proximal shield that you presented in your article, if I'm right, at the IJPRD. And because the area of the papilla is usually the most concern for every implant surgeon, I think. And I want to know what's your follow-up on proximal shield 2?
Okay, so great question. I think socket shield or PET, or root membrane, whatever people call it, is kind of like a really hot, topic right now. Everybody, want to talk about it. Everybody want to do it. So I have my opinion too. Like, I agree with you. It's very technique sensitive. Case selection is extremely important. Now, no doubt, if you leave a shield in there, the gingival, is as if the tooth is there. So the gingival will look great. If you take a picture, you want to put it on a big screen, people are impressed. They will say, wow, bravo, amazing, right? I mean, even if you do tissue graft, bone graft, you know, all those contour grafting, you know, there are many beautiful cases, but you just cannot consistently compare with leaving a piece of root in there, no doubt. However, technique sensitive, case selection criteria, very, very important, all right? And honestly, we are having starting longer term data follow-up. I mean, we are doing a study actually with Hersler and AutoSure right now on that too. And we're starting to see better, longer data. So does it work? Honestly, it will work. Okay, it will work. I've seen it. I have my longest case is around almost 10 years now. It works, all right? And but can that have problems? Just like any procedure, it can have problems. So to put it in a nutshell, this is where I stand. I think that now the guidelines is we know more than any other time before. That means, you know, to put it in a nutshell, we want shield that is thin, not a, you know, thin means probably for sure less than 1.5 millimeters. In my opinion, if you can take it down to 1 millimeter, that's the way it should be, 1 millimeter. Rule number 2, at least this is my experience, okay? You should take the shield down to where the bony crest is. Yeah. Do not put it above the crest like what Hersler original publications or other people had advocated, because I don't care too much about keeping a little bit supercrestal fibers there in there. I don't think that does much in there, all right? And number 3 is if I can avoid touching the implant to the shield, I will try to do that. But sometimes inevitable. And even if it touches, it doesn't mean that every case has a problem. And of course, we all know now from all this great work from people like the Salamas, Howies, and others, they say we need to put a baffle in there to minimize that internal exposure. Okay, great, we know all those. But this is something that I've learned too. For me, at least under my situation, the risk is too high leaving a facial shield in there because it's too technique sensitive compared to, if you look at a lot of other procedures like soft tissue graft, we talk about grafting the gap, we can get very decent results too. It may not be 100% perfect, but we can get very good results. The problem I face is in the United States, where I practices, you know, we have Beverly Hills, we have Newport Beach. A lot of the patients, you know what, if I screw the case up, I mean, a lawyer may just knock at my door. So I want to be a little bit conservative. And so main point is this, to keep the facial contour. Most of the time, I seldom leave a shield in there. I will do my traditional bone graft and soft tissue graft. Now, if there's a really highly sensitive cases, patient high smile line, very demanding, I would suggest to that patient. However, the tricky thing is this, on those patients who are so aesthetically demanding, I also know if the case gets screwed up, let's say something happened, they will come after me. So therefore, for me, I don't do that many facial socket shield, to be honest, for me, all right? Despite the fact that I know they work, all right? However, when you talk about the proximal shield, that part, I do quite a bit more. Not because I have published on it, no. You know, it's just that I found out that the benefit for aesthetics is because bone grafting and tissue graft just cannot compensate for that inter-implant papilla. You know that. You are very experienced on that. And I'm sure you have done leaving a shield proximally, and the papilla looks amazing, right? I recently saw on Instagram someone from Spain, I think Luis Berza or something like that. He showed a 2 implant case, 5-year follow-up with shield. It looks amazing. And the unique thing, what I learned, I want to tell you, what I learned is this. My publication in 2003 on the proximal shield, I was actually wrong. Why? 3 things I stated that is wrong. Number 1 is I say you could keep the shield above the interproximal bone, 1.5 millimeters. I will never do that anymore. Like I say, I put it to the bone level. Yeah. Number 2 thing I learned is wrong is I say the shield should be at least 1.5 millimeters thick. I told you now, because the thicker the shield, the greater the chance of us, the implants, could be touching the shield. Not only that, because the shield thickness, it prevents me from putting the implant at the optimal position. Mm-hmm. So I now modified it to, you know, 1 millimeter thick. And then, of course, now I always put a baffle. Okay, but more important than anything, Omid, I also learned that, okay, from my friend like Joey Chen. You know Joey. Joey actually, I think, had an article in one of your thing, you know, he's a wonderful clinician. He was my former student. I also learned that when we do interproximal shield, we do not, as that article say, that we do not need to extend the shield completely, you know, around the proximal area to the lingual. We don't need to do that anymore. We probably just need to extend it, maybe just barely past the middle, you know, like barely past the midline is good enough. Why? Because it is good enough to hold the bone, but the biggest thing is this, I've learned is, you all know, in the aesthetic zone, the bony photography is scallop.
Yeah.
If we prep the shield following the bony scallop, and you know, most of the time we put the implant platform on the facial aspect of the scallop, and the shield is up there. The shield is like 3.5 to 4 millimeters above the implant platform.
Yeah.
Now, you know, like I show a case on Instagram, I ran into a problem because that shield was like 4 millimeters or 5 millimeters above the implant platform. And worse yet, it gets worse. Because let's say, if the goal is to preserve the papillae, and you already have an implant in the lateral incisor position, Omid, and now you need to put an implant in the canine position, but you need to keep a proximal shield between the canine and the lateral. Just imagine. The facial gingival level of the lateral and the facial gingival level of the canine is always higher than the lateral, right?
Yeah.
Right? Because, you know, it's like canine, lateral, central, right? So if the implant's in the lateral position and you are trying to keep a shield on the canine, just imagine your implant will be way up here, but yet your shield, just imagine, because of the differential between the lateral and that, the shield will even be higher. So I ran into a major problem on the case that I think you may have seen it when I posted on Instagram. I say I have a complication that I think everybody jump on me and say, oh, Joe Ken don't know anything. He has no freaking idea what he's doing, okay? Of course, I don't know because I'm experimenting like everybody. But because of that differentiation, my shield's way up there and I have exposure. I cannot control it. I ran myself into a big problem. So therefore, what I've learned is this. When we do proximal shield, you know, we probably don't need to go extend it all the way, you know, through it. As long as we get into this area here, most of the time is enough. So, you know, I tell you, I'm embarrassed. I published an article and I learned that afterwards, there's a lot of things that I don't know. And I'm still learning. So that's where I started. So to put it in a nutshell, interproximal using the shield to maintain papillae is saved my rear end in many cases. Thank God for that. Facial shield, I don't need to do much. I do study, I'm doing a research on the facial shield right now with one of my very talented clinicians. His name is Rex Liao, very talented clinician from Taiwan. And we're doing it in conjunction with Marcus Herser and Otto Schul. So I'm studying more because I see a lot of potential, but it's just in my practice, the proximal shield plays a much bigger role. That's why I stand.
So we're back again.
Back. Yep.
So actually, it was a very, very great point that you mentioned that we have tooth in different levels, but the proximal area is common it's between them. So if I'm right, for example, imagine we want to replace a lateral incisor and we want to have a proximal shield. So in buccal shield, we say that we reduce the level of the shield to the crest of the bone. So as I understand, should we do it the same way in the proximal shield? So reduce it like a scalloped and following the contour? Yeah.
Following the contour of the bone, or follow the bony scallop, but reduce the shield to the bone level.
Yeah, exactly.
Right?
Exactly. Now.
And I want to share with you can I share with you one quick point? What I've learned is this. Sure. Many situations I notice, especially when I'm prepping the proximal shield, I actually prefer to raise a tiny flap. I can visualize it because many situations, despite all those retraction instruments, just imagine, it's so difficult. It's easy to retract a facial shield using an instrument, right?
Yeah, you're right.
But have you ever tried to retract an interproximal tissue? You cannot.
Mm.
So therefore, a lot of cases when I do flapless, when I span the shield into the proximal region, I notice that I actually under prep it. What that means is, if let's say I get a chance to re-enter the site and look at it, the shield was actually much thicker than I want.
Mm-hmm.
And it creates a situation that not very ideal for me. So I am not hesitant, if needed, to open up the gums a little bit, not a full flap, just right there enough. And then people may criticize and say, hey, you raise the flap, you're going to lose bone and everything. Honestly, I mean, you're a periodontist. I mean, if you raise the diaphragm, not every case, suddenly everything just go crazy. Because why? Your root is still there. So I am not so hard up on raising a tiny flap, and so I can see, and I can just trim the shield under direct visualization very cleanly to the way I want it. And by doing so, I'm actually getting better success in my experience on root shield or PET.
You're right, exactly, great point. And speaking of proximal shield, one of my personal question is, when we want to do the cutting the root actually to save that segment, in buccal shield, usually we cut at the level of the gingiva and then we split the roots into buccal and lingual. So in proximal shield, we do it in a complete opposite direction, right? I want to know your steps in this approach.
Okay, so let me tell you, before when I published that article in 2013, I do a buccal lingual cut, and then keep the proximal shield, right?
Yeah.
However, like I say now, my experience tells us that when we try to keep the proximal area, and this is proximal here, what we need is, as long as the shield, I started with the facial shield. I just extend it a little bit more into proximal. I don't do a completely C shape. So what that means is when I do the cut, so this is buccal, this is lingual, this is the proximal, I will keep like this, you understand?
Yeah.
Facial shields like that. I just extend a little bit more like that. So therefore now my experience tell me my cut will still be mostly mesial distal, but maybe just a little bit tilted, and that's it.
So you do it like a slope, like an oblique one.
Yeah, and still, once again, let me emphasize, I do not need to extend the shield completely encompasses the interproximal area.
Yeah.
As long as it extended into the interproximal area. So in a sense, to put it in a very simple word, almost like a facial shield that everybody now does, extend just a little bit more, and that's the end of the story.
Yeah. You're right. And now let's talk about another aspect in immediate implant placement. When we want to insert our implant, so we really don't want to place large diameter implants. We want to have more space for bone, more space for tissue, and that's proof. Now, speaking of placing our implants regarding its depth of placement. So we have many recommendations. If the bone is intact, place your implants a little bit to the palate, comparing to the center of the socket and about 1 millimeter below the crest of the bone. But I see some researchers and some articles speaking of even placing tissue level implants. And that's something I think it's a risk for, especially in the aesthetic zone. And speaking of all these varieties, I want to know your idea about, number one, placing our implants. Do you prefer to place your implants from the tissue level or from the bone level or from the future margin of the crown, no matter where is the tissue now or where is the bone now? And also comparing tissue level to bone level implants in the aesthetic zone.
Okay, so first of all, I guess the question is twofold. Bone level versus tissue level in the aesthetic zone. And number three is how deep, what should we use as guideline to declare how deep the implant is? Is it a predetermined margin? Is it a gingiva? And maybe there's a third component. Once we identify that, how deep to place the implant.
Exactly.
So let me answer the first question. Bone versus tissue level implant in the aesthetic zone. In my opinion, without a doubt, need to be bone level. Okay, I have done some, previously with the Straumann tissue level implant, in the aesthetic zone, and it give me a lot of trouble. All right, maybe because my experience is not there, but it's not only, you know, you put it above the bony crest, and on top of that, the implant is flare. Right, and now we know everything should be narrow. If the smaller, the better. Okay, so I think that answers your question. In my experience, on level, without a doubt. Now, in the posterior region, if you want to go tissue level, fine, I'm okay with that. Anterior region, we need more room. Second question, how do I, what landmark do I use to dictate how deep I put an implant? Now, over the years, people had used CEJ. Some people use the level of the gingiva. Some people use the bone to dictate. For me, at least my experience tell me the best is, like you described already, the predetermined margin of the definitive restoration. In other words, what that means is wherever the restorative dentist want the crown to emerge out from the facial aspect of the gingiva, that will be my reference point. And once I know that reference point, how deep do I put the implant apical to it? In general, this is my general experiences, 3 but no more than 4 millimeters. In a sense, 3 to 4 millimeters. And you say, Joe, why don't you put it less than 3? If you put it like, let's say 1 or 2 millimeters be apical to the gingival margin, the predetermined margin, you are basically doing it just like a tissue level implant. I've already told you tissue level implant, probably no good. Then you say, Joe, why don't we just go and put even deeper? All right, that means put it like 5 millimeters, 6 millimeters deeper. Honestly, I have done a lot of those too over my career. And I found out that actually the results looks pretty okay, even if you put it 5 millimeters. However, I feel uncomfortable putting the implant that deep, deeper than 4 millimeters plus or minus. Why? Because of prosthetic management. You know, I mean, you're a periodontist, but if you're a restorative dentist, you put an implant deep, making an impression is already challenging, right? Right? Because the implant pin is only this long and the implant's deep, then more than half of the implant pin is underneath the gingiva. How are you going to capture it? Secondly is, if the case you put an implant deep and the case end up getting peri-implantitis, just imagine, it's almost like the coal miners got trapped deep into the shaft, right? To rescue them is a nightmare. So there's no need to do that. So for me, putting an implant really deep is almost like when clinicians, when they prep the crown and they prep the margin way, way, way deep into almost close to the bone. I mean, usually the case will still be okay, but the problem is making impression, cleaning cement will be a challenge. That's where I stand on that.
Exactly. And you know, when we are speaking of placing implants deep, some practitioners use this approach as deep placement to to provide more space for soft tissue on top of the platform of the implant. And some people say that, okay, now that I cannot do soft tissue grafting, I prefer to place my implant, even with the tissue level implants, to place a little bit deeper to provide a space for more soft tissue. But my question is always this, that we cannot predict how will be the remodeling going in which path. So what's your idea on this approach for some clinicians that they say that, okay, now that I don't have enough soft tissue, let's place my implant deeper?
Well, I mean, it's almost like a zero bone loss concept, right?
Yes.
I
mean,
in a sense, what you're saying is literally that. So in general, the rule is, you know, ideally is to have a certain thickness of the tissue. And then if the gingiva is on the thinner side, you basically place the implant deeper to compensate for that thickness. And then there'll be some remodeling and then therefore protective mechanism for the implant. All right, I mean, to a great degree, it is fine. I have no problems with that. Okay, especially in the posterior region. In the aesthetic zone, things get a little bit more complicated. All right, things get a little bit. However, but you need to understand, if you look at the posterior heel side, you put an implant in the heel side. If you take a probe, consistently probe, do a bone sounding on the crest of the ridge, what is the average tissue thickness you get? On an average, is 2. All right. On an average 2. Sometimes you get lucky, very lucky, you get 3, but most of the time it's 2. So what thickness of tissue you want? Well, based on those concepts, you want around at least 3 millimeters. Exactly. So what that means is, if the gingival thickness is 2, the concept is to put the implant how deep? 1 more meter underneath the bone to compensate, right? 1 more meters, not a big deal, right?
Yeah.
It's not a big deal at all. So I have no problems with that. But even if you have a patient that the gingival thickness is 1 more meter, what that means is to compensate, you can put the implant 2 more meters below the bone. Okay, it's not too bad. I can accept that.
Mm-hmm.
In the aesthetic zones, a little bit different. Why? Because you know, again, as a great surgeon, you understand the soft tissue. Let's say in an extraction site, you have the gingival architecture. The patient have no periodontal disease, no bone loss. This is the free gingival margin right here.
Yeah.
Your implant is going to be placed around 3 more meters underneath the free gingival margin, right?
Yes.
Let me ask you, what is the average soft tissue thickness on an extraction socket? 3 more meters.
Yeah.
That's normal.
Yeah.
That's normal, unless there's eruptive problems. So 3 more meters, if you look at those concepts, 3 more meters of soft tissue thickness, is it good enough? Good enough, right? So under such circumstances, there's no point of putting the implant way deep into the bone, because most of our soft tissue thickness in a normal patient is 3 more meters. Now, in an anterior aesthetic zone in the heel side, it may be a little bit different. What's the difference? Because the soft tissue are heel over. And if you soft tissue are heel over on the ridge, you do bone sounding on the crest of the ridge in the heel side anterior. What is the average tissue thickness we get? 2 more meters, because the sulcus is gone. Now, so what does that tell you? Even the tricky thing is this. Now you need to compensate from where is the predetermined gingival margin, right? Wherever it is, for me, I will still put the implant 3 more meters underneath the predetermined margin. Because if you do that, the soft tissue thickness will be 3 more meters underneath, above it. So that should not be a problem. You understand what I mean?
Yeah, exactly. So with saying those points, we can say that till now, if you have extraction sockets, we prefer, if it's possible, to place an implant and not going with the early approach. If it's possible to go with immediates is preferable. But if you need to do like big augmentations, then a stage approach is more preferred, right?
Absolutely.
Absolutely. So now let's go to periodontal disease patients and periodontal compromised patients. When we have a case that the patient is going to lose like 1 or 2 anterior teeth with periodontal disease in his or her mouth. Now, in those cases, do you prefer again going with the immediate implants, or you prefer to extract the tooth, do the cleaning, let the tissue heal, and come back again?
Okay, so great question. Number one is this, the periodontal disease issue. If the patient has periodontal disease inside the mouth, we must control the periodontal disease first. All right, so in a partial edenture situation, this is what is that. If you're doing a couple of implants and then the patients have rampant periodontal disease, we must, again, control the disease. And now then you say, but Joe, it's going to take me a few appointments to do scaling and root planing, and we evaluate control the disease, right? And then, so what happens if the teeth, how are you going to manage the trailing teeth? Well, it depends. If those anterior failing teeth, can wait, I will control the periodontal disease first, and then we do the implant. But if those teeth are so badly infected that it got to come up patients in pain, there's no choice, and patient periodontal disease, what do? Then I will extract those teeth, clean it out, no immediate implant placement, control the periodontal disease, then we put the implant in. So you understand, control periodontal disease. If the teeth can wait, then we do immediate implant placement. Yeah. But teeth cannot wait, control periodontal disease, take those teeth out and just let it heal and put implant in. That's where I stand.
Yeah, and in periodontal compromised patients, because the patient already has lost millimeters of bone around that teeth that are needed to be extracted. So when we do the extraction, in the cases that we can place the implant immediately, so we are forced to place the implant deeper than the amount that we want to place it. So did I get it right that you prefer to place it deeper in those cases? Or if you see it's going to be deep, you prefer to do the grafting first and come back and place your implants in the area that you want. And,
Okay,
and
great question.
yeah,
Mhm.
and just one more point. Usually in those cases, we have lost interproximal bone of adjacent teeth. So maybe even vertical augmentation is an issue for us, and maybe it's not achievable. So what's the best way to manage those cases?
Okay. So again, every situation is different. Again, we talk about in the aesthetic zone.
Yeah,
You have teeth that's failing with periodontal disease. That means crestal bone loss.
yeah.
All right. So do I put the implant deeper or do I do GBR?
Mm-hmm.
It depends. This is what, at least this is what I do. I look at the defect and see how big, how much vertical bone loss is a defect from where I should ideally place the implant. Now, we've talked about where should I place the implant apical-coronally because based on the predetermined margin of the crown.
Exactly.
So once I do the digital markup or the analog markup, I know my predetermined margin. I look up 3 to 4 millimeters. That's where I should put the implant. Then I see, is the bone there? If the bone is not there because of periodontal disease, then my next question is, how much bone is missing there? Now, let's say that from my predetermined margin, if my bone is missing is around maybe up to 5 millimeters, I'm actually okay. Why? Because I'll still put the implant very close to maybe 4 to 5 millimeters from the predetermined margin, and it'll probably be fine. However, if it is more than that, let's say we're talking about 6 millimeters away, then you need vertical GBR. Then I need to ask myself, am I capable of grafting, gaining that bone vertically? Now, vertical GBR is a total different monster because my former student, you probably know him. His name is Istvan Urban. Okay, Istvan Urban is kind of like the king of GBR, right? I mean, I'm so grateful that he was my former student. And the thing is, he can show you, he can gain bone vertically 12 millimeters. I cannot. Doesn't matter what, I can take his class, I can listen to him, read his textbook 60 times, I cannot. Now, so what do I do? Where do I stand? So I know my limitations when I do vertical GBR. So in vertical GBRs, my limitation is this. I have never or almost never have a case that patient have natural teeth with interproximal bone loss and I can gain bone interproximally. I almost so rare. The chance is probably less than 1 to 2%. I don't know about you, but for me, rare. In terms of a horizontal defect, just a pure horizontal defect, to gain bone, I can probably gain around maybe 2 millimeters, 3 millimeters max out. That's where I stand on it. So I know my limitations, as a clinician. So that means my limitations is in a situation with vertical bone loss, I'm talking about 2 to 3. So, and if I then again I look at the predetermined margin, periodontally compromised site, I look up, is my bone loss within 3 millimeters, 2 to 3 millimeters from where I need to put the implant? If that's a situation, I will do a vertical GBR and give it a shot. But if it's more than that, now it's different. I will probably recommend the patient highly to look into maybe artificial gingiva. Okay, unless the patient really beg me, just go ahead and try it, because I know when I do GBR, and many cases when I do extensive vertical GBR, sometimes one time is not enough. I need to do it again. And then after 2 or 3 times, I get frustrated. My patient get upset at me. And then after 2 or 3 GBRs, the rest of the GBR is going to be for free. I'm doing it for free. There's no more money. I'm doing it out from my pocket, for my love of science. Yeah. There's no need. So that's where I stand on it. I look at, if the bone is more than 3 millimeters, as long as the bone loss is between 5 millimeters of the predetermined margin, I don't panic. I can probably put that implant in there and just graft a little bit. I will be fine. Yeah. But more than that, I know my limitation. My limitation, Joe Ken's limitation on vertical GBR is probably a couple more meters. Okay, yeah. In general.
You're right. And Joseph, nowadays, not nowadays, actually, it's like many years, but the trend, or maybe the talking about guided surgery is becoming more and more popular. So we know that it can be predictable, it can be completely computer guided, and we can be maybe even faster. But my question is this: in a hand of experienced surgeon like you and people around the world, do you think that for being predictable in the aesthetic, it's crucial to go through guided surgery? Or is it possible to achieve the same results, again, like without guided surgery? Because people like you and all educators, true educators like you, you have lots of follow-ups for your cases, even at the time that there was no guided surgery. So the reason I'm asking this question is this.
Internet somehow again, but no worries. I got most of your question.
Yeah.
About guided surgery and
Yeah.
aesthetics. First of all, you know, when you ask me comparing analog cutting off a little bit. Can you hear me? Yeah, I cannot hear you right now. I don't know why.
Yeah, now
you're muted. Okay, now I can hear you.
Yeah, we can start answering the question again regarding guided surgery, and can be predictable without guided?
Perfect. Well, when we do guided surgery is actually very predictable. It makes surgeons' life a lot easier. All right, surgery become a lot faster. So it's great. We love guided surgery. However, the trick is clinician must remember how good guided surgery will be is totally depending on the input that you put onto the computer. You understand? You know, guided surgery can be fabulous, but it's human being that put the data into the computer to plan that case. In order to plan it well, that clinician must have very good basic foundations in periodontology, in prosthodontics, and soft tissue management. So success, you know, computers is great, but it totally depends on the input that was put into a computer, and that input is the human being. So I always suggest to the students, if you want, I mean, it's great to do all these fancy guided surgeries, flapless guided surgeries. However, if you don't understand foundation periodontology, it's going to be difficult. In fact, I tell you, Omid, I always tell my graduate students, nowadays you see young students, they all want to do flapless, all these fancy things. The beauty about being a great periodontist is what? Is understand soft tissue management and the biology. And how do you understand soft tissue management? Unless you open the flap, you know, suture it back and forth thousands of times, you don't understand soft tissue management. So in fact, for the young students, if they are focused on all this fancy guided and flapless surgeries, they are missing the boat. They are taking the true education away from them because they are just almost like a general dentist, any dentist out there. Because any dentist, they can just do a flapless surgery. But the beauty about being a specialist, you can soft tissue management. So I really love guided surgery, but to train to get there, you must go through the basic foundations so that you can input that concept into achieving guided surgery into the aesthetic zone. Because doing guided surgery in edentulous site is easy. Doing guided surgery in aesthetic zone is a lot more challenging because you got to think about the soft tissue thickness, where the predetermined margin is, and all those elements there.
Actually, yeah, you're right. Because you know, as you said, when we know the principle, when we know how to handle the case, then everything can be under control, and we should not be dependent to some approaches. When we know what we are doing, it's fine. When we don't know and we are depending to a technology, and even in my country, sometimes dentists ask the companies that, please, this is a CBCT, make a guide for me and let's do it. And they don't even understand what to do with that guide. They cannot even understand that this is not a case for immediate placement or even placement of an implant without doing any augmentation procedures. And that was the reason I wanted to ask you this question. Now, if you let me, let's move to the posterior zone and in the healed ridges. And the reason I want to start this conversation on posterior zone, is talking about short implants, because they are now available in the market and some good quality short implants are available. And comparing vertical augmentation procedures, as you mentioned, some people do great amount of augmentations with non-resorbable reinforced membranes. Some do it with the titanium mesh, some with the tension screws, some with the Huri plates. And all of those cases that we see are beautiful. We have also some good cases, some failures. And now that we have short implants, actually we have it like for many, many years, but now they've become more popular and more precise, better say, and better surfaces. Do you prefer to go with vertical augmentation or with the short implants when you have a scenario, especially in the posterior area?
Excellent question, Omid. And first of all, there's always different philosophies and concepts in dentistry, in any aspect of dentistry, such as GBR versus short implant. It's another concept.
Yeah.
But is that right or wrong? There's no right or wrong, because it's like a religion. There will be some people that just totally believe in GBR, and they will, doesn't matter. No, you cannot convince them. It's like if someone believes in one religion, you try to convert someone to change religion. Have you ever tried that, Omid? Do not go there. Do not, never. Because, and I'll tell you, even if that religion is wrong, even that religion tell you, jump off the building and you will become a better person. I mean, you say, wow, it's not making sense. But some people will believe that and say they will jump off because that is what they believe. So therefore, we cannot, it's hard to change people, okay? Because whether right or wrong, even if, let's say you feed vertical GBR, we know there's a lot of failures, no problem, they will still do it, all right? And so where I stand, I do both. I've done vertical GBR, I've done short implant, because why? Because for me, I have no credibility to talk if I have not done vertical GBR and I criticize vertical GBR, you understand, or short implants.
Yeah.
But the reality is, for me, I know that the risk of vertical GBR, the chance of failure during the healing phase is higher, number one. Number two is this, even if it heals and it looks beautiful, you put the implant in. If you get the patient back 10 years later, does that mean everything is perfect? Now, I don't know about you. Have you ever experienced that you did beautiful vertical GBR and then you follow the case, you put implant in, 5, 8 years later, suddenly there's a big bone loss around the implant?
Yeah.
Then you say, why? Now, in my opinion, when I have a patient with posterior region that have bone loss, I will typically look at what are my limitations are, how much I need to gain the bone. Again, my limitation is probably around 2 to 3 millimeters. Mm-hmm. If it's more than that, under my hands, I will probably just tell the patient, let's go with a short implant. I have seen many short implant cases, and the literature proves that they work perfectly fine. I mean, listen, if you listen to people do all on 4, all on 4. Yeah. 4 implants supporting, like 14 teeth, and it works. Why would a short implant not work? I mean, it works. Yeah. So, and besides, the patient will have less suffering, less pain, and less whatever. Let's put it this way, Omid. I think this is a key point I want to share with the audience. For me, when I treat a patient, I always ask myself, if this patient is your mother, your dear mother, or your dear wife, or your dear girlfriend, or you, is this you, what will you do? Mm-hmm. I think the answer will probably right there, be right in front of your face, okay? Yeah. Will you, let's say, have a full arch of teeth and you need to do a fixed complete denture? Will you every tooth keep a shield in there or not keep a shield? Or will you do that 6 millimeter vertical GBR? How much suffering you will make your mother go through? I think that answers a lot more for me, and I tell you, I have many doctors. They tell me they will do this. But when I ask them, if this is, the patient is your mother, will you do that? Suddenly they say, and think a lot, and or maybe the patient is you or me. So for me, as a dentist, I will tell you, if I will tell you by rule, if I have a tooth that need that have periodontal disease. Let's say a molar hyperfixation.
Yeah.
All right. And even let's say 40% bone loss with implant bony pocket, with +2 mobility. I guarantee you that for me as a dentist, I will try my best to save it.
Save it, exactly.
I will try my best. I will say, let's do osseous, let's do regeneration. I will look at all the different possibility. And then on top of that, I will definitely pay a lot more time, home care every day, to make sure. And even if that tooth, trust me, have 50% bone loss, all right? I'll say, let's try to hang on as long as I can until I have no chance. I will say, let's go for the implant. That's me, all right? Same thing, simple. If I have a defect here, all right, missing a tooth, and the surgeon say, I can build your ridge perfectly with a vertical GBR. Or we can put a short implant in because you're missing 4 millimeters of bone vertically. I guarantee you that for me, I'm going to say, put that short implant in there. Because, and then if the short implant failed, let's say 8 years later, it's okay, I'll put another implant in there.
Yeah.
It's that simple. That's where I stand. And I think you as a dentist, you feel the same way. Yeah. I mean, I saw you on Instagram. You recently posted, I think on Mother's Day. I see your lovely mother, your lovely family. I mean, if she's your patient, you'll be very careful. Okay, nothing crazy. Yeah. It's okay, nothing crazy.
Exactly. That's very true. That's very true, and I think it should be all of us decision that first try to save the tooth. And then if it's not possible at all, not that we don't want to, but if it's really not possible, then think about other options. And I think that's one of the points that really need to be highlighted in different symposiums and courses around the world, because nowadays so many dentists they just want to learn a technique. They just want to just do huge grafting. Actually, I am a great fan of grafting, but believe it or not, I really wanted to share this with you because having your opinion is very important for me. When I follow up my patients, I see that sometimes I did a great grafting for the case, and in the follow-up, I see some bone loss is happening. And I try to control the patient. And the lesson I learned from those cases was that, okay, now I place this implant, now I face like 5 millimeters buccal bone loss on that implant, and I just cleaned an implantoplasty, and the implant is now stable for the next 5 years during my follow-ups. And at that time, it was something that came up to my mind, and actually I do it in so many of my patients nowadays, that I say like a KISS principle, you know about it, all the people. I heard it first time from Dennis Darno. And keep it simple. It said, keep it simple, silly, when you look at the mirror. And, in some of my cases, especially in the posterior zone, sometimes I place my implants and even the bone is very thin. I'm not going to say I don't do grafting all the time, but sometimes when I see the patient and I see maybe there is no need for doing huge grafting and there is no aesthetic issue here. The patient is 67 years of age and he or she just wanted to have a good function and healthy function. And maybe only I do a soft tissue grafting there, leave the bone there thin, and do the soft tissue grafting only for the purpose to make sure there won't be any foot trap there after the prosthesis. And Joseph, believe it or not, when I follow all those cases, I don't see any change, even when the bone is very thin. And sometimes when I have dehiscences there. So what's the difference between that dehiscence or the case that I do the implantoplasty? I think nothing. And we can do cases very simple, especially in the posterior zone and in the patients that they're not really in the aesthetic demand that much. And maybe soft tissue graft can solve lots of these problems. I don't know if I'm right, but I really want to have.
Now, let me tell you, Omid, what I just heard from you, the thinking process. What that tells me is this. Now, all along, honestly, before this, we never really talked before, right? but I know you're a young, talented clinician, and you're very inspired, you're well connected, you've done a lot of amazing things. But I will tell you, just hearing from you just now make me believe, okay, you being a good clinician, I start seeing a glimpse of greatness. Because once when a clinician start thinking that, all right, so start thinking about their patient's well-being more than their own personal intentions.
Yeah.
All right. And start understanding the limitations of medicine and understanding that in medicine, there's a lot of compromises and yet they work perfectly. I'm telling you, I start seeing a glimpse of greatness in you, my dear friend.
Thank you.
I'm sure you're great already, but I'm just saying personally, anybody that have that thinking process as a medical personnel is showing signs of greatness and maturity. Because my graduate student always tell me, Omid, and just like many dentists, oh, we treatment plan the case. There's options, short implant GBR, but the patient wants GBR. That's why I'm gonna do that big GBR. But you know what? Many times as dentists, do you know that whenever we present treatment options to our patient, let's say option 1, 2, 3, 4, do you know most of the time what option the patient end up selecting between, let's say you give the patient 5 options. Do you know what option the patient usually end up selecting?
No.
Most of the time, the option the patient end up selecting is the one that you as a doctor tend to push.
Yeah, exactly.
Now, why does the dentist push that option despite there are many options? Sometimes because of this money.
Sometimes they want
because
something new.
Sometimes I haven't tried that procedure yet. I want to try it. I just learned it. I just flew to Germany to learn that procedure. I want to try it.
Yeah.
Or maybe sometimes because I need to give a lecture. I need to document a case. I need to document that case. Sometimes because out of the different options, I know this option better. So you know what? You as a human being, if you, let's say one day, long and behold, we need to end up to be in the hospital. All the people are doctors. Do I trust every single doctor? No, I do not. Mm-hmm. Okay, because you know that many doctors have many different motives. And sometimes the motives is not for you, it's for them. So let's say if Omid, you have a heart issue. I mean, God bless you, you're not. But let's say if we have a heart issue, you need to go to see a doctor. I mean, hell, I'm not going to go in there, just go to any hospital and just say, okay, go ahead, do whatever you want. Yeah, go for it. Heck no. The first thing I'm going to check is, first of all, what type of doctor are you? What type of doctor are you, first of all? Okay? I want to find out what is the psychological profile of you. I want to treat by someone with good human decencies. Not looking at money as the number one thing, not looking at being famous as the number one thing. If that doctor, all they care is, I want to be famous, international known. I want to drive that Rolls Royce, lots of money. That's just crazy, okay? I want to be like just, I'm the king. I don't want that kind of doctor.
Yeah.
The best doctor are the ones that very humble, study a lot, keep improving themselves, understanding the limitations, and always think about, you okay? Are you okay? I want to make sure I take care of you. Honestly, it's not the degree, Omid. It's not the specialist, whether you're a prosthodontist, periodontist, maxillofacial, it's not. It's the human decency in us.
Exactly. That was the point and I'm so happy that I received the confirmation the way that I think from you, because nowadays, I mean, I can say maybe since 2 years ago, that's really my approach. And I really try to keep some cases that I can do like beautiful GBR. And I think that, okay, if I place this implant in 30 minutes, everything is done. And the patient is even happier. No pain, no extensive procedures, no long-term follow-ups. And yeah, that's I think great. So Joseph, you know, I really enjoy having this conversation with you. And I think I can talk like hours and hours, and I know that your time is precious and limited. So if you let me, I just want to go to some cases very quick, and just to have some of your ideas on that, to be able to also share with the participants. So I share my screen now. Okay. Now you're having my screen, right?
Yep.
Okay, so this is the first case that I wanted to share with you. Actually, this case was a 25-year-old guy came to the office, and you can see the recession. The point is that when this patient came, he visited like 5 periodontists and some dentists. And all of those practitioners said that these teeth should be extracted and we should do implant placement. And what I said to the patient before doing anything, I said that, first of all, I think you can do the soft tissue grafting the way that I see it, but I asked myself that, okay, let's go and extract these teeth. They are not mobile. Mobility is 0. And what will happen next if I extract these teeth? Where is the bone and where is the tissue? What will happen to the aesthetic? So that was the first thing that came up to my mind before doing the extraction, because extraction can happen in less than a minute, but doing the reconstruction may take years and years and even not being predictable. So first of all, I want to know your idea about this case and the way that you see it. Do you ask the patient about, do you offer the patient about the reconstruction in such cases, or you prefer to save teeth regarding the age of the patient?
Okay. Saving teeth is precious. I will tell you that as a clinician, I have been in practice for more than 20 years now. At the beginning part of my early on in my career, I don't think I really appreciate about saving teeth as much as now. The more I practice, the more I start looking into, a lot of cases that we can save the teeth. And if you save the teeth, it's actually more powerful than putting an implant in there. So looking at this case here, I want to see how the CT scan looks like. I want to know the periodontal charting. How does it look? However, okay, perfect. And this case has a very distinct advantage. Let me tell you what. I look at the gingiva. First of all, I look at the papillae between 8 and the 2 central incisors. The papillae is there.
Yeah.
That is great news. What that tells me is there's some sort of bone supporting that papillae. All right. Number 2 is I looked at the periapical radiograph. I see the interproximal bone of the 2 laterals. In my opinion, they look super. So that means interproximal bone of the J teeth is great. The bone between the 2 teeth is probably great. And thirdly is this. I look at, again, the gingival margin of the crowns right now. The crown CEJ, whatever the crown CJ is. If you see that, the central incisors.
Yeah.
What I see is this. It is actually positioned more coronally than the ideal situation. Why? Because when I look at the gingival center for the lateral incisors, how can the central incisors gingival center be more coronal than the laterals? What that means is this: if you try to visualize with me, and then I'm going to go ahead and use this little thing called the annual date, and you'll not understand what I mean. Ideally, the gingival margin will probably be somewhere here.
Yeah.
Right? So, yeah. So that means these tooth have been extruded. And normally, if you look at this papillae, we know central incisors papillae should be almost same level right here. That means the papillae will probably should be right here.
Yeah.
So what that means is if I'm going to do a crown, my visualization will probably be like this. I mean, sorry about my drawing, it's hard to draw, but you get the idea.
Yeah.
Right?
Yeah, exactly.
Something like that. Okay? So what that means is I have extra papillae. All I care is right now, I'm missing soft tissue right here and right here.
Yeah.
If you look at Chiro's classification in periodontology, Chiro's classification, formerly, it's almost like a modification of Miller's classification. If you have, so this is like a Miller 1 recession, or this is like a Chiro RC1, RT1 right here, right?
Yeah.
Why? Because the papillae is good, interbursal bone is good. So only thing is the root is prominently on the arch.
Yeah.
So I will probably go in there and see. Now, of course, I see a bony pocket here. All right. But bony pocket like this, a lot of times is manageable.
Yeah.
It's very manageable and grafting. So, and like you say, the beauty about this case is there's no mobility. That's very key there. Now, of course, I'm missing CBC scan, I'm missing perio charting. However, like I say, based on this right here, this is RT1, Chiro RT1, or Miller 1. So what I'll do is this.
In soft tissue.
I will put the crown right here like this. The crown will be like this, right here. And then I will go in there and flatten out the emergent profile. I will do a tissue graft right there, maybe a strip of deepithelialized FGG. And then, of course, first of all, do periotherapy, okay? Clean everything out, close debridement. And then I think this case, in my opinion, based on what I can see, you probably is capable of doing quite a bit of maintaining those teeth. I believe you are capable of maintaining them, in my humble opinion. Yeah. And then those teeth may be able to maintain for years.
Exactly. And Joe, one of the things that I wanted to mention here, first of all, do you do crowns first and soft tissue grafting second, or you prefer to do the soft tissue grafting first and doing the crown secondly?
Okay. So in this situation here, I will probably, for me, I'm not going to be aggressive. That means I'm not going to go in there and just start prepping yet. The thing is, I want to, if possible, if I can shorten this papillae a little bit better, to shorten this papillae, I may need to do a little osseous right here to shorten it, because otherwise it will just stay there. Now, what I'll probably do in this case is this. Initially, I love what Zucchelli taught me, or even Cortellini. What they always suggest is this: when you see a recession, okay, most periodontists are going to say, oh, that's a big recession. This is a big recession. But what we learn from Cortellini is, number one, where's the crown margin? Where's the crown margin? Ideally, crown margin's right here. So what they do is they'll go in there. I'll just go in there, add a little bit composite here first. All right? Add a little composite right here, just to contour it, so that there's a contour like a CEJ right there, right? Like a CEJ right there. So that the soft tissue can heal to it. So we know there's a limitation when we do perio surgery. You understand? Yeah. So I'm not necessarily, I'm going to go in there and just put a big old crown in there. I'm going to see what I can do first. I'll just maybe quickly add a little composite there, okay, if I can, all right? And then I'm going to just go ahead and just do a root coverage there.
Great. And
let it heal. Yep, go ahead.
Yeah, no. So in this case, because I just wanted to share a point. So usually when you do the composite and when you want to do the soft tissue grafting, do you prefer to go like a tunneling approach, or you prefer to reflect the flap and do the graft?
Okay, great question. Every situation is different, all right? Nowadays, so let me tell you, people are really emphasizing a lot of tunneling procedures right now. A dear friend of mine, okay, you know him, his name is Otto Schur.
Yeah.
Otto.
Yeah, Otto.
You may not know, Otto spent 1 year with me in Loma Linda, 20-something years ago, okay? So, two of my former dear friends slash student, okay, Otto Schuh and Istvan Urban, okay, is amazing. So Otto and Herster, they're really into tunneling procedures,
Yeah.
right? Or my dear friend like Pat Allen,
Yeah.
Pat Allen, right?
Yeah.
Now, if you look at other people, like maybe my dear friend Kelly, he doesn't hesitate to raise a flap to root coverage. There's no one perfect magical way, all right? Again, I'm not hesitant to raise a flap if I need to. Let me tell you, the beauty about, there's always pros and cons in every dental treatment. The beauty about tunneling is there may be, less scarring, okay? And the healing is a little bit faster. Patient may have a little less discomfort. But the drawback when we do a classical sulcular tunnel is you sometimes cannot pull the soft tissue down passively. So what do? If I'm going to do tunneling, all right? So let's say I'm going to do tunneling here. I'm going to do a tunneling procedure, all right? Nowadays, besides tunneling, the problem is when you do tunneling, do you mind just back up one shot? Do you mind just so I can share with you on that? When you do tunneling, the problem is this. It's hard to free up the tissue up high. And, so what we do is this. And what I do tunneling is this. Sometimes, and also when you have really sharp, thin areas, sometimes tunneling is kind of like a little bit complicated.
Yeah.
So if I do tunneling nowadays, you know what I do? I will go in there and always augment it with some sort of tunneling procedures. So I can, from the top, festival and tunnel from the top and tunnel from the top. So I free everything up.
Yeah.
I seldom do a classical tunnel unless the recession is very small. But anything like that, I will go from the top too. So I do double. But if not on situation that is really narrow, like this, to be honest, when you have narrow incisions, sharp and narrow things like that, I will not hesitate to go in there
and reflect the flap.
And then coronal procedure and deepithelialize here, and just do a classical coronal advancement, and that will be enough too.
Yeah.
So that's where I stand on that.
And in this way, we can make sure that the connective tissue is not going to be even exposed, and the predictability may be going to be even higher. So one of the things—
Totally agree.
Yeah. And one of the things that I wanted to share with you during this case was I was imagining why these roots are too much convergent together. And what was the etiology for that recession? Because the hygiene is good. We see some like intrabony defects in the distal aspect of the centrals, but everything seems to be good. And as you said, we decided to do the subepithelial connective tissue graft for this case. And you know what happened next? This is the slide that during the surgery we saw. Elastics around the roots. And when we asked the patient again, he said that he had a diastema, and the dentist put 2 elastics, removed one went down to the apex, and that was the reason that brought the roots together convergent and losing.
Amazing.
Exactly.
Amazing.
Yeah, you can see the defect is exactly the path of the elastic going to the apex. And it was really interesting. And then because we cannot see it in the radiography, the elastic, it's nothing to be, diagnosed. So it was very interesting for me. And that was the reason I wanted to share. And we removed the elastic, and we just cleaned the surface, reduced the prominency of the root, and we did the soft tissue graft for the patient. Actually, the patient was living in another city, so I really asked him to come. He was very happy. I asked him to come because I wanted to do the follow-up and photographies. He couldn't. He sent me a photo with his mobile, but this was not bad. You know, you can see how tissue grow there, and we can do lots of great things about it, but the patient couldn't come back. But what I wanted to share now is the radiography of the patient, Joseph. Look here. This is 3 months. Look how bone grow back without putting any graft material there. And I think the main reason was that because the root surface was intact and not diseased, and when we remove the etiologic factor, the bone can grow back again. So that was the reason I wanted to share it with you also.
Perfect.
Yeah. So I think these are for the audience. I really recommend you all to go to Joseph Can's Instagram page, and I really recommend you all to read the caption of each of these photos. That was real lesson for me reading your caption, Joseph, because it's really make us think and really think in a way that you described it, how to treat our patients and how we can minimize the over treatments. And sometimes maybe they're necessary, not necessary. And the reason I just put this case, maybe I can say that let's do it as our last case, because I think we are enjoying the time. Actually, I'm personally, but I don't want to take your times very long. But speaking of this case, you did a very beautiful approach here, lifting the papilla, putting the connective tissue graft there. And this is really something amazing that you post. And well, usually the papilla is a concern for all of us, and we want to have a maximum aesthetic results possible. But when we see such cases, I want to know your idea about it as you present it beautifully. If the patient, another patient come back with the same scenario, and definitely we have a concern for the papilla, what's your recommendation for making sure the papilla stays there? Or do you think if it's necessary to make sure that the soft tissue can form there, or no? We can go with the pink aesthetics as an option.
Well, basically, we know, papillary regeneration, surgical papillary regeneration, is it easy or difficult? What do you think, Omid? Is surgical papillary regeneration easy or difficult?
I think it's almost impossible, even long. I think in long term.
Yeah. Okay. When you say almost impossible, in my opinion, I totally agree with you. I mean, what are the chances of success is probably less than 1%, honestly. Okay. So, and in fact, if you look at this case here, I did the tunneling procedure, and if you look at the healing, I actually lost papilla. Yeah. I lost papilla. So anytime when you see patients with papillary issues, do I do surgeries? I mean, I seldom go in there and do surgeries anymore. Yesterday I had a session with my dear friend Steve Chu. Mm-hmm. I saw Steve Chu is on your list. Steve is a very dear friend. We had a very good discussion yesterday. I asked Steve, does Dennis do, papillary surgical regeneration? Steve told me almost never. Under my hands, it doesn't work that well. So when I see a patient with a papillary problem, I usually will go with pink porcelain. Or maybe increase the contour of the crown under most circumstances. That's where I stand.
Yeah, I totally agree with you, because I think that was one of the points that I really wanted to highlight it. And Joseph, I have to say again, thank you so very much for your time, for this great discussion. I truly enjoyed every second of it. And I want to thank you so much again for accepting this invitation, and really looking forward to see you very soon. And hopefully, if the situation is under control, again, I'm mentioning this, dear Joseph Can will be our keynote speaker of the 5th International Symposium of Complications in Implant Dentistry, and the recipient of Excellence in Execution Award of 2021. Thank you so much again, Joseph.
Thank you so much. Very nice meeting you personally. Have a great one. Thank you
so much. Stay safe. God bless you. Bye-bye.
God bless you too. Bye bye now.